Dear listeners, please listen in to this fascinating interview with long-term care executive Richard Mollot as he describes the work he's doing to address the challenges elders face in nursing homes and assisted living facilities. Richard also talks about innovative solutions for families and elders to help improve the care they're receiving in these facilities. Stay tuned. Welcome, Richard. It's really a pleasure to have you here. I've been looking forward to this interview. So please tell us a little bit about yourself and the Long-Term Care Community Coalition.
Oh, thank you. So again, my name is Richard Mollot, and I'm the Executive Director of LTCCC, the Long-Term Care Community Coalition. And we are a nonprofit, nonpartisan organization that advocates for improved care and quality of life and dignity for residents in nursing homes and assisted living.
Yeah. How long have you been doing long-term care advocacy?
For almost 23 years now. 22 years, 22 years.
Oh, wonderful, wonderful. As I'm listening to you and you mentioned the word dignity, and throughout my interviews, that's sort of the one thing that's really surfacing as sort of the core issue when we look at elder care and its intersectionality with health care and even legal issues and finance issues, because we all know that sort of they affect and overlap. How would you define dignity in nursing home or assisted living facilities?
Sure. That's such a good question. No one has ever asked me that. I would define dignity as a few things that I think are indicators of dignity. One is autonomy, the ability to make decisions about oneself, what one is doing, how one is receiving care or services, how they're being provided, the ability to make choices about care, choices about food and entertainment activities, etc. I think that's a really important component. But I think the other thing would be to be treated humanely and as a human being. I think one of the issues that we have and why this work can be extremely challenging is because people don't see older adults, and especially older adults or people with disabilities that have significant needs, as being human. Mm-hmm. We kind of, as a society, we tend to marginalize them. And I think that really speaks to and that, it happens systemically, as I said, in terms of society, but it also happens on a personal basis. I think too often with workers, certainly much too often with owners, operators, and managers, and even sometimes with families.
Wow, there's a lot to uncover there as I'm listening to you. The other thing just to add to what you're saying is that the dignity, actually you mentioned this, in the provision of care, right? And what is quality of care in the nursing home environment or the long-term care environment? The reason why I'm asking this question is because of coming from just caring for my parents, right, and my in-laws, and who have varying sort of socioeconomic backgrounds, right? And sort of navigating that space and trying to establish that quality of care, I find it's, I'm sometimes confused. So how would you sort of define that?
Well, there's a really good definition in the federal law and the federal rules for nursing homes, and that is that nursing homes have to provide the care and the services necessary for every resident to attain and maintain their highest practicable physical, emotional, and psychosocial well-being.
Wow.
When I do programs, for families and for the public, I always say it's a mouthful. It's just that's really hard. Even someone who's been doing this for over 20 years, it can be hard to wrap your head around. And first thing I remind people is it's not highest practical, it's highest practicable. So everything in the nursing home environment, practicable means what the individual can do if they is capable of doing or capable of achieving both clinically and in their quality of life and in their emotional and psychosocial well-being what they're able to achieve with the services, with services and supports. And it's not practical, which is where my head often goes when I hear that sentence. It's not practical in the sense of the nursing home, or I'm in a nursing home. This is the amount of staffing that they are providing. They mostly, for many of them, the majority of them, frankly, are short staffed. So they say, "Oh, this is the best we're able to do, based upon the staffing we have." That's practical, but that's not what the law requires. The law is very resident centered.
Okay.
So every single thing we talk about, whether it be clinical care, whether it be avoiding falls, whether it be mealtime, whether it be dressing, whether it be services and activities, the social activities, they all have to be resident centered and focused on helping the resident, again, attain and maintain what they can, their highest practical achievement. And like one example, if I may, is that when I started this, I was 40. Now I'm 61, and I would just say, if I can avoid being put into a diaper, I don't want to be put into a diaper. Didn't want it when I was 40. I don't want it when I'm 61. I'm not going to want it when I'm 80 if it's avoidable, which means that I should never, and this is a part of the federal requirements, I should never be put in a diaper because there's not enough staff to help me go to the bathroom,
Okay.
help me walk to the bathroom, or move my wheelchair to the bathroom, etc. But too often we hear the exact opposite happen. And that's really just, one example. It really touches on everything. And the rules are quite comprehensive about that, recognizing an individual's individuality, that we all have different, sociological backgrounds, ethnic backgrounds, et cetera, that inform what we want, where we want to be, and what our goals are. And those are always important, whether you're 40 or you're 90, or whether you have dementia or don't have dementia, et cetera. Those are always important, and they really inform my work in trying to advocate for residents, because they're requirements. They're not wishful thinking. They're not supposed to be wishful thinking. Anyway, they really are the requirements, and they're what nursing homes get paid to provide.
Yeah. Thank you for sharing that. I'm not sure if you know, but I, many years ago, decades ago, I was a nurse's aide in the South Bronx.
Wow.
In a nursing home, and with an aspiring nursing major. Well, that took a different turn, but nonetheless, it's sort of, as you're talking to me about, and specifically patients who, if you could avoid them being in a diaper and get them into the bathroom, and we know that a saturated diaper can lead to a breakdown or make them susceptible to wounds and pressure wounds, and that turns into sores and very hard to heal for the elderly, especially if they're either bedridden or even if they are wheelchair bound, right?
Mm-hmm.
So what are some of the challenges that you face with dealing with or advocating for creating this sort of, just again, their dignity, right? Fighting for their dignity, and specifically like issues of shortage of staffing, issues about practicability. That's the term you use, right?
Yes.
Yes. Issues about really the quality of life for these individuals in these institutions. What sort of challenges that you face on, if you can explain to us maybe examples on a national level, state level, or local level? I think for the audience, they would love to hear that.
Sure. Well, I think the biggest issue that we face in nursing homes and in assisted living as well, and I think it's important to distinguish, one, that nursing homes and assisted living are different, because a lot of time, even in news articles, I see them conflated. Like the headline will say nursing home, and then the article will say assisted living, and they're two very different things. For nursing homes in the United States, we have really strong regulatory standards, and they all get back to that highest practicable. I've worked on those standards for my entire career. They're really good, and they've been good for a really long time. The problem is in terms of their implementation, which we could talk about. For assisted living, there are virtually no federal rules. There's no federal requirements as to quality. There are no federal requirements for assisted living in respect to who's providing care. There are no federal requirements for reporting when there's been an accident, when someone has died or suffered because of neglect or abuse. no reporting whatsoever, no requirements on the federal level. The states have rules. Those rules tend to be very weak. So the differences here are that in the nursing home world, we have really good rules. They're just not well enforced. And that's the heart of what we do, is to say, how can we get these rules implemented in the lives of residents? So a lot of our focus is on advocacy. We mainly focus, I would say, on federal advocacy. And the reason for that, I think maybe is useful to understand, is that, again, we have these strong federal rules for nursing homes. Nursing homes get most of their money from taxpayers through either Medicaid or Medicare. That's the vast majority of money that nursing homes get in. So that's what they count on to make their profits. And that's how we have the leverage to have these rules in place. States can have additional rules, but really it's the federal rules that are the foundation for nursing home care. And the federal government has an agency, the Centers for Medicare and Medicaid Services, which oversees nursing homes. And they contract with the state. So every state has usually it's called the Department of Health or the Department of Public Health, and they're supposed to be enforcing those rules. And the problem, the heart of what we've been doing over the years, is trying to improve enforcement, because enforcement is really poor. It's really weak. Some of the things we were talking about, the ability of someone to maintain their continence, what we were just talking about before, not be put in a diaper, that's very rarely enforced. Even safe staffing. And we know that most facilities, just based upon the numbers that they themselves provide and studies showing what is needed to provide decent care, most facilities fail to provide that level of staffing. So that really kind of gets at the heart of what we see. And so some examples are, as we talked about before, the ability to maintain control over one's bladder and bowels. Not everyone wants to talk about that, of course, but it's important to everyone if you can. And if you have the ability to regain control, say you lost control, but maybe you had a colostomy, maybe, I'm not a clinician, just to be very clear, but maybe you had an issue, but then it's up to the nursing home. They're being paid to help you to achieve that, to provide therapy services, to provide the services necessary. Unfortunately, too often we see the opposite. And then you have this cascading effect from short staffing, which is so persistent and widespread in our nursing homes. So we have, as you mentioned before, pressure ulcers is what they're called. When someone develops an open wound, usually on their heels or on their buttocks or someplace else where they're resting in bed or on a chair or a wheelchair, and they're not getting the movement necessary, and that becomes a wound. Especially if you're older or have certain disabilities, you can become more prone to that because your skin can break down more easily. The issue is that one of the issues I should say is that to some extent we accept that.
Wow.
People have very low expectations of nursing homes. And we expect that because nursing homes are the professionals, that they know what they're doing and that what they tell us is the truth. So if someone says, we had to put your loved one in a diaper, or they developed a pressure ulcer because this is just what happens when they get to be that age, or if they have diabetes or whatever, people are inclined to accept that because it's the professional who's telling you that.
Yes.
And you put your loved one there because you trust them. Even though, I think for most people, they think, nursing homes are not great places, and I'd rather die than go to a nursing home. We hear that. But when you actually bring your loved one to a specific nursing home where you're going in, you are differently thinking, okay, this place is going to be okay. It may not be steak and lobster, it may not be silk curtains, but it's going to be okay. My loved one is going to be safe. If my loved one was not going to be safe, you would never put someone there.
Right.
So you've already kind of made that jump. Right. And unfortunately, too often people become then a statistic.
Right.
They become one of those almost 10% of people in this country who in nursing homes who develop a pressure ulcer. Another big issue, if I may, that we've been working on for over a dozen years now is, and this is one of the questions you had originally proposed asking, is that they're given antipsychotic drugs. Antipsychotic drugs are very powerful medications that are used to treat very specific conditions such as schizophrenia is the most frequent one. Sorry about that. What the government Inspector General found in 2011 was that about 25%, 1 in 4 nursing home residents were receiving these antipsychotic drugs. Now, the number of people who will have a diagnosis of schizophrenia in the general population is well under 2%.
Wow.
25% of
25%.
residents.
Wow.
Yes. And those drugs carry a Food and Drug Administration FDA black box warning. Do not give these drugs to elderly people with dementia because they increase the risk of death, heart attack, of stroke, of Parkinsonism, of falls, etc. This is one
Really?
of the biggest issues. Yeah, it's one that we focus on for quite some time, is that residents were and still are being given these medications in too many nursing homes as a convenience of staff. Same way that residents are put into a diaper so staff doesn't have to answer a call bell and take them to the restroom. Residents were being doped up, chemically restrained with these antipsychotic drugs to make them easier for staff to care for. And it's not to make things easier for the nurse aide or for the LPN or the RN. It's really to make it easier for a facility to understaff. To just
Really?
not have this. Yes. That's really one of the biggest issues that we see, because those drugs are so dangerous. For a lot of families, and I totally understand this. I have family members, one family member right now in a nursing home. What happens too often is that someone with dementia, and that's most residents in assisted living and about half of residents roughly in nursing homes, have some level of cognitive impairment. And what too often happens is that person will have so-called behavioral symptoms. They may be crying, they may be lashing out, they may not want to be provided care, they may resist it, is the word I'm looking for. They may resist care, etc. And so they become agitated and they are given these drugs. And as a family member, I could totally understand. You see your loved one agitated. And again, the professional is saying, we have to give them these drugs because they're upset and these drugs will calm them down. And as a loved one, I would say, of course, I don't want to see my mother upset and agitated and not getting care. I want her to be calm. But in fact, what those drugs do is, one, they have these black box warnings, again, that they're very dangerous. They, again, all the things I said, heart attack, stroke, Parkinsonism, etc. But they don't address the underlying symptom of why the individual has that behavior. And one of the biggest things I've learned in my career has been that all of those so-called behaviors, it's communication. Every single time it's communication.
Really?
It's the individual with dementia saying, I'm comfortable, I'm scared, I'm bored, I'm in pain. And they don't have the ability any longer to say, I have a stomachache. I haven't gone to the bathroom in 3 days and my stomach hurts. So they become agitated. Or when care is provided, say, especially in a rushed manner where someone comes in and say I'm sitting in a chair looking out a window and someone comes in and puts their arm on my shoulder, that's scary. But I could say, if someone did that to me in my office, I could say, hey, you frightened me. Please don't come up behind me. A person with dementia doesn't have that ability. So of course they're going to take a smack, or that's how they can address the situation. So all behavior is communication. That is the biggest, I think, honestly, the biggest thing I've learned in my career. So what is supposed to happen in that situation? Not drugging them up, even though that seems like a right idea. My loved one is now agitated. Let's calm them down. Yes, we want them to be calm, but what really should happen, and this is part of the rules, again, that we were talking about, ensuring that everyone is able to attain and maintain the highest practical well-being, is two things. Is that one is we're supposed to be finding non-pharmacological interventions. What is going on? What is triggering? What happens? And I could tell you stories. I know, for instance, one study that was done here in New York City found that the resident, every day at dinner, the resident would be sitting at the table, and every day he would get up, he would throw the table up.
Really?
Yes. And so, why was this happening? And they were going to give him drugs. And, and of course, it disrupted the other residents at the table. It upset them. People weren't being fed. It was very disruptive to the whole room. And they talked to the child of this resident, and they found out, they just took a few minutes, and they found out that this resident grew up in a very traditional Italian family.
Okay.
And he was the man of the house, and he was used to being served first.
Oh,
So the only change was just putting his plate down first.
okay.
And then that didn't happen again. So a lot of, again, it comes back to that resonance. And what are we doing to center our care and our communications on meeting the resident where he or she or they are
Okay.
as a person? And there are so many stories. There's another one, if I may, that a resident every afternoon she would become very agitated, and she would start, she would be swatting around. She'd be upset. She'd be upsetting other people. And finally, they realized that every afternoon she was in a wheelchair. Every afternoon, they took her into the TV room to watch TV, and they put her up against the side of the wall. And every afternoon, the blinds would the light would come in from the blinds right into her face. And she didn't have the ability to say, she couldn't move herself. And she
Right.
didn't have the ability to say, hey, can someone please move me? All she knew was she had this blinding light right in her eyes.
Right.
So
Right.
she was upsetting. It was uncomfortable. And so, of course, how else, you only can act, you can only communicate with what you have available to you.
Right.
But again, nursing homes, assisted living are being paid to provide the services for the individual, to understand what is going on with the individual and to understand how to address their needs in an appropriate way. So we see this over and over and over again that, facilities do what is really convenient for the facility. They diaper people, they put on a drug. Again, that's now, it was 25% when the Inspector General found that in 2011. And then, there was a federal campaign to reduce drugging that had some impact, but it was very minor. And then COVID hit. It was a free-for-all, frankly, in nursing
Right.
homes without families coming in, without inspectors coming in. And now the drugging rate is way high. It's about 20%. So still, even though we know all these bad things for many years, even with the black box warnings, 1 in 5 residents. So one thing that we did, if I may, one thing that we did,
Sure.
we're advocating for this. We're advocating for stronger enforcement of these rules that have existed for over 30 years. But one thing that we've turned to do, we've had some, frankly, some generous help from a couple of foundations, is educating families, educating people, others who are working with residents and families so that they understand that these drugs are not an appropriate treatment. In fact, they're not a treatment at all. They're really just a chemical restraint, and that every resident has the right, because, like I said before, we tend to accept what the authority figure, especially a medical authority figure, says. This is what we're supposed to do. This is what we have to do now. Okay, but in fact, there are good federal rules. So a lot of what we do is we have a whole dementia care advocacy toolkit now that people can easily understand what the rules are, what these expectations are, and then, help them to be implemented in the lives of their residents, help them to get change in the practices in their individual lives.
Wow, this is fantastic.
Thanks, Harlem.
Yeah, just to
Excuse
hear what families go through and what elders go through, and again, if your inability to communicate, as you mentioned early in the discussion, is compromised or impaired, which sort of gives me I started thinking about the involvement of families in their elder or loved ones' care, right? I
me.
think it's important to be or as much as you can, to be involved, right? And present, if you will. And I can't tell you the amount of, again, from personal experiences as well as just professionally, what I've heard. Families they live far apart.
Yes.
So they're remotely trying to, either through a phone call, a Zoom, an email, this exchange. But if you're not there, how can you then be able to detect or determine that your loved one has these communication challenges?
Right. I think that one thing that we have done some work on and are continue to work on is empowering not only individual families with knowledge and tools that they need, but also encouraging them to join or create family councils. Because under the federal rules, every nursing home is required to allow families to join together and residents to join together privately. We
Okay.
actually set up at the start of COVID, but we've continued and will continue to provide it, a free Zoom room for families to start and join family councils. We actually have a family council toolkit everything on our website is free to use and share, but ways in which people can join together. And I think, again, having had family members in nursing homes, it's a lot. Whether you're close by or far away, it's an awful lot. And I just can't do another thing. But I think that if you're able to see past that, it can be really helpful and make life easier to join as a family counsel, because you're not just one person trying to get something done, you become a group of people.
Okay.
And so that strengthens your voice, because sometimes people say, oh, that one's difficult or that family member's difficult. There's a lot of, and oftentimes it's legitimate, fear of retaliation against the resident when the family member's not there, retaliation against the family member saying you can't come here, stuff like that. Those things are not legal, but unfortunately they do happen. We've been doing a lot of work in recent years on trying to identify and address this fear of retaliation. But if you're working as a group, all those things dissipate. So because you're a group, so they just can't blame it on one person. And there are strong federal rules about responding to resident and family councils. And also, if you're far away, you can do it via Zoom. And I know family councils that do it totally via Zoom or as a hybrid, but it's a way to be involved, because it's hard. And yes, too often residents who don't have a family member or don't have a family member there, they really suffer. They get even poorer care than the average nursing home resident. They shouldn't, because we have nursing homes are required to obviously provide the same care to everybody, but they don't have that voice there that's saying, my loved one hasn't been bathed, or my loved one hasn't been provided this care. We saw that with COVID, where no one was allowed to come in, where it was just catastrophic for residents. And not just because of COVID, but because of not having the family members there to monitor. So having a family council can be really powerful. It can make your life easier by improving your advocacy, by sharing some of the burden of advocating with the nursing home, by making it much more effective, et cetera. So we really, and of course, if you're at a distance, helping you to be a active participant, hearing what's going on in the facility from others who are there firsthand, but also, working together to be effective advocates for your residents. And if I may, the way that we started, the reason we started working on this and got foundational funding to work on it, because there were studies showing that nursing homes that had an active family council, care in those nursing homes was better, not just for the residents who had a loved one on the family council, but for all of it. So they really do. There's a big bang for your buck. I know it's believe me, I know, everyone, we're working, we have kids, we have a lot of different things pulling at us, but it could really, once you get started with it, it can make things much, much easier and much more effective for your loved one.
Yeah, and this is really great to hear. And it sort of reminds me of a consumer advisory board committee.
Yes.
Yeah, but this is sort of more it's extended to the family. So sort of a family advisory board. So they listen to the concerns, they hear what the challenges are, and then they just and I guess they had the opportunity to speak to management to then address it.
Yes, there's a number of different ways. There's under the federal rules, every nursing home is required to have a grievance officer.
Yeah, this is really such an informative discussion, Richard. Again, thank you. I'm learning so much as you're sharing with us the nuance of care in a facility, be it nursing home or assisted living. I have a question. Can you help us to understand the difference between rehab and sort of that joined rehab or co-located rehab and nursing facilities? Does that sort of applies to you and the work you do as well? Because a lot of what I hear with a lot of elders after they fall or they have a knee replacement, etc., they have to go into nursing/rehab.
Yeah. There's a lot of confusion about that, and understandably so. So nursing homes provide both short-term rehab care as well as long-term care. And the big issue, one of the big issues in terms of the industry, is that short-term rehab is paid for generally through Medicare, whereas long-term care is mostly paid for by Medicaid. And Medicare pays typically a lot more money than Medicaid does per day. So Medicaid rates, and they vary significantly, but it could be It's not small amounts, $250, it could be $300 a day on average, could be even more. For Medicare, it could be $4, $5, $6, $7, $8, $9, even $1,000 a day. So
Okay.
there's big money, big profits in Medicare. And so you see the industry has become increasingly for-profit over the years. It used to be many more that were run by churches or other religious groups, or that were run by charitable organizations, and were very mission-driven. We're seeing more and more facilities again over the years that are run for-profit. It's about 70% now that are for-profit, as opposed to not-for-profit or government-owned, or like a county facility. And we're seeing, even in respect to the not-for-profit, an increased corporatization. So I've kind of digressed a little bit, but the way that gets back to for someone who's coming in for short-term rehab is that there is a big incentive for nursing homes to take in those rehab patients because there's so much more money. And it's important, as I've kind of hinted at, it shouldn't be important for every family member or every individual going into care to worry about this, but I think it's worthwhile to know that the industry has become, again, very corporatized over the last 20 years, especially very sophisticated. So we see these companies that are measuring down to dollars and even pennies the costs and benefits of providing more staffing versus someone having a poor outcome, suffering, and potentially suing. People rarely sue, but there is that, on occasion they do. And, or the prospect of getting a fine, which is it's pretty rare, and the fines tend to be very low. And that's why staffing is poor. So what we see is that the people go in for rehab, but facilities have different incentives in terms of what kind of care they provide. I assume you're hearing all this in the background.
Yeah.
So facilities are measuring down again to sense how much they're spending and what the cost and benefits are.
Yeah.
So the way this plays out, in terms of the finances, is that a facility that has, for instance, lower census, fewer number of residents in their beds, will want to take in whoever they can.
Okay.
But if a facility has higher census, and oftentimes better facilities tend to have higher resident population, census is what we call it, they tend to be the better facilities. But then there is an incentive. I don't say everyone does this. Facilities are different, but again, we're seeing more and more facilities do this. There's a higher incentive to bring people in who have the big short-term care, the big rehab money coming in, and then to get rid of them when that big money is gone or is threatened to leave. So there's been significant lawsuits by different states around the country that that people were being discharged inappropriately once they got the care. But I think, just to get back specific, and I apologize for digressing, the biggest issue to me with the difference between the short-term rehab care and long-term care is that there's not that much of a difference. So when I talk to people, like my parents are in their 80s and they have friends who fall or something happens and they have knee surgery and they go to a nurse for rehab, my mom will say, "Oh, she's going for rehab. It's not like going to a nursing home." That's not true.
Okay.
That is just not true. And I think one of the most profound reports that has come out in my career was a federal report in 2014 that found that 1 out of 3 people who go to a nursing home for rehab is harmed within the first 2 weeks of entering the facility.
Harmed, you said?
Harmed. Yes.
Wow.
1 out of 3. And 59% of that harm is likely the result of poor care, medication mismanagement, etc., avoidable.
Wow.
6% of those people die, again, within an average of 2 weeks, 15.5 days to be precise.
Wow.
This study is now 10 years old. And I still remember those precise numbers because it's so shocking. Because people think, "Oh, I'm going for rehab." It's a whole different story. And you might be put on a nicer floor, But the issues that exist with the nursing home, if issues do exist, they are still going to affect you. And when I remember when I told my board about this study when it happened, and one of my board members is a former nurse in a nursing home, and her response at the time, I still remember, was, and those are the people who can talk. Those are the people who can complain. Those are the people who know that, hey, I was supposed to get my medicine at 9:00 this morning, or I was supposed to have physical therapy, PT, at 11 a.m. this morning, and no one came by to give me my medicine. No one came by to give me my therapy. Could you imagine what's going on with the residents in long-term care, many of whom have dementia?
Okay.
If you're not able to say, hey, this is the wrong medicine, or hey, no one came to give me my medicine, or
Right.
hey, I need help. I'm supposed to get therapy to help me regain my ability to walk.
Uh-huh.
What happens to those people? It's chilling. So again, I think it's really important for people to understand that short-term care or the name short-term care is not a panacea. And from our perspective, in addition to that, is that it shows that even when nursing homes are getting a ton of money, they're still too often not providing the basic care and services that people need to retain and maintain their highest practicable well-being.
Wow.